Thank you, Mr. Chairman. Thank you, Prof. Gargiulo. Without your support, I wouldn't be here. I think my friend Enrico and my Prof. Gargiulo will make my mission easy to present our experience in Bologna about CO2 and geography in EVAR. One of the main problems of EVAR are the renal impairment post-EVAR. Renal impairment is an independent predictor of mortality after open repair and EVAR. And the contrast-induced nephropathy in EVAR ranged between 2 and 16% of the population. A systemic review and meta-analysis indicate unreporting renal dysfunction, and they report 1-year renal function deterioration in nearly 18% of the population. A lot of studies are published in the literature evaluate the use of carbon dioxide as a contrast medium for EVAR. But all of these literature have the lack of and the drawback of using manual injection, so no control of gas amount at all. So the use of CO2 in EVAR not standardized yet. A lot of literature use carbon dioxide as an alternative contrast medium for EVAR, as it has a character of non-nephrotoxic and non-allergenic gas. A new technology using an angidroid injection system, which an automated one, is needed to prevent the air contamination hazards which cause vapor-like lock phenomena. And here are some tips for the better EVAR imaging. As we know, CO2 and the air have the similar radio opacity, so on the final angiogram we may have artifacts and noise in the final image. To overcome this problem, as Enrique told us, we have a protocol of using active carbon 2 days on the day of the operation, and avoid of fruit and vegetable 4 days before the operation. Carbon dioxide have the character of buoyancy, which means that CO2 floats over the blood. So the vessels originating from the anterior surface of the aorta are better visualized than the posterior originating one. As presented by Prof. Gargiulo, the anterior branches are well visualized using iodinated contrast, but also the posterior one. But using CO2, the anterior one have a better visualization. Also, for total filling of the aneurysm sac and the visualization of the renal and the hypogastric artery, we have to correct setting of our angidroid system, using pressure between 3 to 500 millimeter mercury and using a volume from 80 to 100 milli. And now we are heading to reporting our result in Bologna, which published in 2018 in the Annals of Vascular Surgery. Reporting is a standardization of carbon dioxide automated system for endovascular aortic aneurysm repair. The aim of our study was to report our preliminary experience with the new method of CO2 automated injection. We include all patients in the period of the study, all interventions performed with automated CO2 injection and controlled with traditional iodinated contrast medium. We use iodinated contrast medium through suprarenal aortic pigtail catheter, while CO2 was delivered through a 10 Frenchies positioned in the external iliac artery. As you can see in this photos, this is a triple way. We use one for CO2 and one for iodinated contrast, and the pigtail in the area above the renal arteries. Our endpoint was visualization of renal arteries and internal iliac arteries and the detection of any endoleak, and safety of the CO2 after the procedure. We include in this study 31 patients between August and December 2016. 10 of them was having chronic renal failure, and with nearly equal percent of suprarenal and infrarenal fixation endografts. On the initial diagnostic angiography, we can have visualization of the lowest renal in nearly 60% of the patient, but we lost the visualization in nearly 40% of the patient, and 100% visualization of the hypogastric arteries. As you can see in this photo, this is a visualization of the renal artery using CO2 and using the contrast iodinated medium. In this photo, you can see we can visualize the renals using iodinated contrast, but we lost visualization using the CO2. As a preoperative characteristic and the morphological characteristic, there is no difference between the group which we visualize the renal artery and the group which we don't visualize the renal artery, except for the lumen volume with statistical significance. On completion angiography, we have 100% of visualization of both renal arteries and of lowest renal arteries and both hypogastric arteries. And for endoleak type 2 detection, we have 10 patients with endoleak type 2. On comparing the endoleak type 2 detection using carbon dioxide and iodinated contrast medium, we can detect in 10 patients, which represent 32% of the patient of the study population, versus only 2 patients of iodinated contrast using iodinated contrast medium. This difference may be explained by the low density of the gas and the connection between the hypogastric artery and lumbar arteries, so the sac is easily filled or overestimation of the using CO2 for the endoleak type 2. We compared our results and we found that 10 patients have endoleak type 2 using CO2 versus only 2 patients using iodinated contrast medium versus 5 patients using contrast enhanced ultrasound. So we have also some drawbacks and adverse event occurs in 3 patients who have severe hypotension. 2 of them had nausea and vomiting just before the onset of the hypotension, and all solved spontaneously. We conclude that CO2 angiography can be used safely in EVAR with excellent hypogastric artery visualization and excellent type 2 endoleak detection, and renal artery visualization may be improved. We can be effectively use EVAR performed with injection of non-toxic carbon dioxide through an automated device. In some cases, to visualize for more visualization of the renal arteries, we can use a single injection of a minimum dose of iodinated contrast medium. So the points of strength for a CO2 automated system for EVAR are no renal contraindication. It is a simple procedure. Internal iliac artery visualization in 100%. Techniques to be improved for the renal arteries visualization. The promising new result for endoleak detection. And thank you.